Welcome, first of all, and I'm John Teeter. I'm currently with KPMG, but prior to that I spent about 3 decades at the Department of Health and Human Services and ended up here in D.C., at the departmental headquarters as their chief architect and deputy CIO, and upon occasion I served as their CIO whenever they needed somebody. So I've been around this industry for quite a while, and I've known both sides now. And one of the reasons that I was so excited about doing this with Joel was because for years I have seen the need for the business side of healthcare to join with the IT side, and for government to join with industry to develop that path forward that you heard from our plenary speakers. And so, this, I believe, is that opportunity, and I'm going to challenge you all. I'm listed as the moderator, but I'm going to try and stir things up a little bit unless you all help me do that. I've been known to walk around and stick mics in people's faces and ask questions. So, don't be surprised if I do that. And if I offend someone, then just tell me to get away. But which that happens sometimes with me. But what we want out of this is we want to have ideas. We want to have ideas that we can act on, because you heard from our plenary speakers that ideas, plans, strategies are nothing unless we can take action. And so that's what we want from this first session of this Health IT Forum and the Health IT Working Group. Is we want a list of your best ideas for how we might be able to transform the business of healthcare. And so if that involves information technology, then great. If it doesn't involve information technology, then we need to get the business side of the house working on that as well. But we need your ideas for how to improve the business of healthcare and transform that business. Okay? Level set? Good? All right, so we've got a number of experts up on stage here, and they're going to give their thoughts on some areas of transformation. We've given them pretty much free rein to raise whatever topics and whatever issues they want to raise within this context. And so with that, I think I'll let them introduce themselves, and we'll continue on with your comments. Please.
Introduction and the full intro, or just name?
Whatever you prefer.
All right, sounds good. I'll give my opening remarks then. My name is Mark Nagar. I work for HHS in a dual role. I am an IT vendor management specialist, as well as a project manager for a new ID Lab sponsored project called the HHS Buyers Club. We don't buy anything, but what we're trying to do is revamp IT service acquisition across HHS, and in large part make a contribution as well throughout the federal government. The White House is also on board with this. Recently you may have heard of the U.S. Digital Service being announced, a TechFAR handbook, Digital Services Playbook, all different names, as well as the innovative contracting case studies. There's a significant push right now to try new methodologies and experiment across the federal sector to acquire IT services better. I use the term acquire and acquisition more than procurement, because procurement is only one aspect of acquisition. Acquisition involves a tremendous amount of stakeholders. To give you a quick sense of my background, I spent the last 4.5 years with CDC working on international acquisitions in support of global health. I have a strong interest and background in innovation, and I only arrived in DC in April to work with HHS Chief Technology Officer Brian Sivak and the Executive Director of Innovation at HHS, Greg Downing, to operationalize a lot of these efforts, to sort of, gradually make a shift to improve IT service acquisitions. I'll keep it short, but to give you a quick sort of 3 elements and goals of what we're trying to accomplish, we are developing new, easier models for IT service acquisitions. We're also including within that lessons learned, pitfalls, best practices and guides. A lot of what you may have heard in the previous plenary session, people talk about, but we're trying to put it all in a central place and enable collaboration. Additionally, we're testing a lot of those methodologies as well as the models we're creating to ensure they work. And last but not least, and probably the most fun part for me, is engaging and educating the HHS workforce and stakeholders on implementing those and iterating. And when I consider stakeholders, I think of procurement staff, finance, IT, program managers, et cetera. It's not limited to any piece, any role. I think that there are a tremendous amount of people that are involved, and everyone has a role to play. Beyond that, I could touch on a lot of challenges and opportunities that exist, and perhaps we can get to that at some point during this discussion.
Hello, got me on? Good morning, everybody. So 3 cups of coffee in right now, and I'm not allowed to walk around and talk. This could get a little ugly. So Shane McNamee, I'm a physician in the VA. I am a clinical informaticist and at basis a rehabilitation physician. I spent a lot of years in the trenches building and running polytrauma rehabilitation centers for the most severely combat wounded. In the VA, we partner up with our colleagues in the DoD to do that care for the kids, and I say kids most likely, or mostly who got most severely injured, and really caught early on the unbelievably important concept of data interoperability, and not from a bits and a bytes thing and making sure that the wires are connected, but making sure that when Sergeant Smith came down and he was a double amputee and he had a raging hepatitis from something, that it was just as important that when he showed up with his vital organs, that the data about his vital organs showed up at the same time, right? And really got passionately involved in this over the years, and really have built kind of this concept in my mind that this data subset that we all own, we like to talk about patients like there's somebody different than we are, right? We are the patients, it's the people, and this concept of data as this extra vital organ, right? It is almost as important as making sure that the heart is in somebody when we're caring for somebody over time. So, we've seen this change, significantly. And I work primarily in the VA-DoD interspace in terms of data interoperability with the Joint Legacy Viewer, if you've heard of this project that we've just brought out. But it's really nice to see this cultural change, and these cultural changes are necessary and to push through. And by that I mean we finally have, as a people, as a group of patients, and not as hospital administrators and IT folk, now have the expectation that when you walk into a new facility, into a new physician's office, or go to the ER, you expect that your data is there, right? You're now shocked that it isn't. 10 years ago, you weren't. You had no expectation. You were your data interoperability vehicle, right? Now when it's not there, we're surprised and to some degree angry. And you're angry because you're vulnerable and you're fearful and you're anxious. It is that kind of thing that's actually going to change this world, right? And now that we have the technology to do it, to make it happen, this expectation is this group of people and many others pushing it forward. So to some degree, when we just talk about that technical interoperability thing, are the bytes and the bits flowing? I'm not really that concerned about it anymore. I'm much more concerned about what happens when it actually works, right? When the data actually flows into the moment of healthcare. Do we have healthcare providers out here? Anybody? Has anybody looked at an electronic health record system recently? You feel like you're in the cockpit of an airplane? right? There's so much data. There's so much there right now, and that's in these little data silos that we work in, right? This is just in your facility. When we begin to take all the data from everywhere, and it's the patients, it truly is this patient-centered or person-centered care thing, there's a tremendous amount of cognitive burden associated with that, right? How do you make that make sense for providers so they can more efficiently and effectively get there? But then how do you jump over the medical legal piece when you're actually now responsible not just for what's in front of you from your own hospital, but from everywhere else? How do you allow people, practitioners and providers, to get into that data most cleanly and clearly so they understand it and they can use it? So this concept of, and we always talk about usability, but also usefulness, this at the point of care, taking this data interoperability and make it both usable and useful at that moment, is really challenging. In there is all the performance issues, the speed of it coming back. You sit and you wait 3 minutes on a website that's going to book your airline ticket, you're never going to use that website again, right? You're going to go somewhere else. And we have major issues there. We have major issues in terms of stability of data flowing through, and then the human concept of trust and whatnot comes into the back of there. So really, my focus in terms of kind of moving forward, and very clearly at this space, well, at this time in the VA, which is, did I mention that's where I work early on? I probably should have, right? So we are building a whole new electronic health record system. The Vista CPRS did what it did to healthcare, and we are embarking on this Vista evolution now. And one of the pillars of Vista evolution is true data interoperability, meaning that when I fire up the next GUI that we're developing right now, all your data is there. It all comes into there. There's a middle tier that's going in called Vista Exchange that actually allows that to happen, to aggregate and to cache that data and feed it forward into it. And so then the big challenge now that we're seeing is, how do you make that quickly make sense in a world where relationships in medicine are going away and you are generally a novel patient to a novel provider? How do we visually make that information make sense? How do we navigate that appropriately? Great opportunities exist in visual display of health. We see these in a lot of different areas, heat maps and things along those lines. So when you see someone for the first time, you get a pretty good idea of who they are. One of the biggest things that we don't do well yet, and I think is a great opportunity for us, is how do we take your goals as a human being when you go and you see your medical care provider and allow those to be ordinal, right? And how do then we take those and pivot the healthcare system to drive towards those things? It potentially can take, and this is my last comment, it potentially can take this thing that we call the healthcare system, which is really a disease management system, right? And potentially flip it on its head when we talk about our personal health and having our personal health goals drive. A lot of words there, but there is actually a possibility that we can do that if we manage data appropriately. So lots of other comments, but just great to be here on a panel of really smart people, and look forward to talking to you here today.
Hi, I'm Margaret Donahue. I'm a family physician and a clinical informaticist. I work closely with Shane on interoperability at the VA. My focus is really more on exchange with external partners, but where Shane has been spending a lot of focus on exchange with the DoD. But both of us really recognize that this really has to be one approach, because it is one patient. And how do we really get that patient-centered record to be sort of the basis of this new Vista Evolution project that we're working on at the VA, this modernization of Vista. So I just joined the VA at the beginning of the year. I've always been working for a private hospital with close relationships with private EMR vendors, Cerner, NextGen, Epic. I was responsible for the installation of the interoperability platform at my hospital to connect up all these various EMRs that we used. And I also was involved in the Rochester Rio, which is my hometown. I was on their management committee, and I've really seen how interoperability in a local community can be successful. They have established it so that everybody is receiving into their electronic medical records discharge summaries and labs and admission notifications, etc. at the pretty much universally throughout the town. There's something like 800 unique patients who have signed consent, because New York State is an opt-in state. So, you know, it is successful at the local level, and it's really pretty exciting to step up to the national level and really talk about how we can make it work on the national level. And this is especially important for veterans because, you know, 70% of our veterans are receiving care outside of the VA, along with VA care, and this number is growing, as we all know, as we're going to be increasing the amount of purchased care that we purchase, that we really need to be able to bring that information in somehow electronically into our systems so that we can incorporate it into our medical record. So I work on the Veterans Health Information Exchange Project, also known as Veeler Health, the Virtual Lifetime Electronic Record. And our two main products are Exchange through the eHealth Exchange and the Direct, establishing Direct. So the eHealth Exchange, many of you probably know this already, but is being sponsored by My Healthy Way, and we're partners with My Healthy Way in this, so that we do have one national data use, the DIRSA, you know, whatever that stands for. That agreement that we all do, there's one national agreement that you can sign to participate in the exchange. So we have currently connected with 28 partners through the eHealth Exchange. But this actually represents a much greater number of hospitals, because our strategy is to really try to connect up to local HIEs and large organizations like Kaiser and other large medical organizations. So our partnerships represent many, many hospitals and many, many patients. Our current goal is to continue to roll out about 3 partners a month. We're really good at doing Epic, but we need to, through the Healthy Way, but we really need to connect more with other vendors as well, and maybe get more involved with the Commonwealth Project as well, to get connected with those vendors as well. We have lots of people waiting to join in after we do some more technical upgrades that we're working on, like the CCDA. So the Direct project, I'm sure you're all aware, is basically secure provider-to-provider email communication, and it is a national initiative that's trying to make some of this interoperability easier for providers, especially smaller providers. We also are, the other part of our Direct project is what our Blue Button download, and that's starting up soon this month in pilot sites where patients will be able to actually download their CCDs and transmit them to their community physicians through the Direct project as well. There's a lot of things to work on with that, but it has potential to really empower patients to transmit their information themselves to their external providers. Currently, our current use cases with Direct right now are around purchase care, trying to get mammogram results and trying to communicate with our partners we're purchasing maternity care from, and we're expanding that quickly. So, there's a lot of exciting work going on. I think the VA is really, besides SSA, we're really, the organization that's doing this national level exchange. and we really want to make it grow and want support in getting it done. But there's a lot of issues. It's very difficult work, and I made a list here. It's pretty long, but you know, I mean, the one issue is our federal consent policy is difficult because we have to have veterans sign to release information, as opposed to a lot of states where there's an opt-in consent policy, or in New York State where you consent to view. So we don't really, you know, our providers aren't necessarily motivated to get consent because they can look at stuff without getting their consent, but our external partners need that consent to be able to view our data. So the consent policy is a little backwards, in my opinion. You know, and just the inconsistency about consent policies in general across states makes a national exchange difficult. Patient identification, you know, we're all going to really struggle with that if we want to exchange nationally, and I think that's already been talked about quite a bit. Just the whole, right now the exchange is it's a federated process where you go out there and you ask every one of your partners, do you have this record? So the record location process is slow, and Shane is a physician. You heard him complaining about that, you know. So it won't work unless we make that record location process quicker. Semantics. I mean, people have been talking about this, and you know, in Rochester, as I said, there's a lot of exchange of information, but the semantic interoperability is not there yet anywhere. And we've got to really, you know, engage both on the federal and the private level to get our data interoperable. And that, you know, there's just really basic stuff to start with, and that needs to get done. So we got to keep working on that. The CCD also, a lot of vendors are not adequately populating the CCD and the CCDA, including the VA. And then just probably from a physician's point of view, there's a couple of really big things that we need to worry about, and one is just the clinical workflow of all of this. I mean, how do we really bring it into the provider's daily work? And right now, nobody's doing that very well. I mean, there was just some AMA report about how physicians are just besides themselves with EHRs, and about how it's so complicated and does not work in their daily workflow. And interoperability just throws a whole nother huge level on that. There's too much information. We need to really, you know, Shane was talking about the cockpit. There's too much information, and also, you know, doctors are really afraid about medical legal issues. So there's a lot of questions about data ownership. What am I responsible for? What can I go look at without having to be responsible for it? You know, those are the kinds of questions we need to have conversations about. So my list keeps going.
It does.
It does. It does. But, you know, we need a direct address book. We got to get that done on a national level, so that if we're really going to make direct work, we've got to make it like an MPI. Everybody has a direct address. That's universal, instead of all these HISPs having different addresses for everybody. So I will stop there. We have a lot of work ahead of us. There's a lot to do for sure to make this work, but it's worthwhile. We got to make it happen for the patient.
Great. I'm Barbara Camerata, and I'm very lucky to be married to a veteran because I'm feeling in really good shape. All the info we'll be getting. I'm an attorney at Sidley Austin, and I practice in both the healthcare and the privacy groups. I've worked at several law firms over the years and been in this area for a long time. I think I'm the token lawyer here today, trying to chime in on the privacy and security issues to the extent I can help. My background with privacy and medical privacy actually started way back when I was a student at Georgetown Law here in DC. I was a research assistant for Larry Gostin, who was one of the thinkers behind the whole HIPAA law in the early 90s, doing a lot of the grunt work on how the state laws work to create the federal framework. I graduated in 1995 and moved out to California with my husband, and initially did a lot of hospital work, did the early HIPAA. HIPAA was passed in 1996 and all the beginning stuff. But the last 5 years or so since HITECH has been passed and I've been back on the East Coast and working at Sidley, my practice has shifted significantly over to sort of the business associate side. A lot of companies got pulled into HIPAA without realizing, that really applied to them. And also a whole bunch of really interesting secondary user type things. We do some of these mobile apps companies with questions, companies trying to use social media in different ways and wondering what applies to them. A lot of really interesting ones in sort of the health promotion wellness, trying to be an interface between providers and patients, but using things like texts, which raise serious security issues. And then very recently, probably most of this year, we've had a big wave of just the very standard IT companies who have seen a great opportunity. They know the technical stuff, they know how to do things, and they're seeing all this data, and they're coming up with ideas between the cloud and interacting with the individuals and using apps and mobile approaches. They want to kind of jump into health data. I think they see a lot of economic opportunities with what they already know and what's available out there. And so they come to us with not just the privacy type questions, but the full range of healthcare, because a lot of the other healthcare laws are pulled into that. And then the other large part of my practice, which I'm actually going to take advantage of the free rein they gave us today to talk about, is with the clinical diagnostic laboratories and a lot of the pharma and medical device companies that are jumping into genetic and genomic testing areas. We've been doing a lot of work in this area as both the big companies are joining it, and a lot of these little companies who are generally started either by physicians or business people who might have just one test or one idea, but get things going. And I think I just don't have a lot of time, but just kind of wanted to throw out a couple of observations, mostly because it's a great group of thinkers, and this this used to be called personalized medicine. That's now such a big term that covers so many things. People in this area kind of call it precision medicine, and it's this idea that individuals, can get their genetic or genomic profile to improve their care. They can find out if they might get certain kinds of diseases. They can find out if a chemotherapy drug will work for them. There's just a whole range of things. The science is amazing. Just to step back quickly for people who aren't doing a lot of this work yet, the genetic tests are specific to a gene, so that means like a breast cancer gene. They test on that one thing and tell you something. The genomic area is up and coming, and in some ways more interesting. There's new technology called next generation sequencing technology that lets them do one test on a person but come up with like 300 genes. So they have access to all this data about many genes, and they hold on to it and can keep it as technology develops further. The testing is usually based on looking for biomarkers within the genes, and every day there's new biomarkers discovered and new things that are learned. So you do the test once, you can hold on to that data and go back to it and pull out future results later. Still very much in development, but obviously creating huge amounts of data on all sorts of different things. It's cancer is kind of the biggest space, but pain management has been getting huge. They're moving into Alzheimer's and some of these other areas as well. But anyway, the couple of things, I thought I'd just focus on two things to point out among the many that are out there. Was just the idea that, first, there's in some ways a heightened privacy interest here, because especially with the genomic, they have a big chunk of you. You are clearly identifiable from that information. It's not just, having one or two pieces of PHI. But one thing that's I've just been thinking about lately is this whole concept of trying to share the data and how we want to be able to do that. We sort of have two different, or policies moving in two different directions. NIH recently released its genomic data sharing policy, which is, in my opinion at least, says what it should say. The government is funding this research, let's share this data, and here's how we should go about doing it. But on the other side of things, you have a lot of private industry-funded research that is not subject to the common rule, is not under those government requirements. And oddly right now, which is a little bit of a snapshot in time, things are kind of pushing in the other direction just because of other policies. These companies start up and they spend a fortune on the research and development trying to create these tests, and they manage to get the funding to do that. Initially, the idea, a lot of these people were med device pharma people, they thought they would get patents on it. The U.S. Supreme Court came out with what was called the Myriad decision, which said no, no patents on the DNA. There's some patents available on some of this side science, but not on the main product. So no protection there for them. The next way you get money for lab tests is reimbursement. You get Medicare and private payers to pay for it. That's a huge topic that I do spend a lot of time in. But the bottom line there is that reimbursement's been really difficult to get. It's taking 18 months to get payment for one test. It's a big process involving sharing a lot of your data with the government to do it. And at the end of the day, the amount you're getting is a lot less than they were expecting. So reimbursement is still very much in flux. The policies are developing, but again, not where they want it. So what's left for them is this data that they hold. Some of my clients, have 500,000 lives, genetic data on all these different people, and they treat it as an asset. They, think it's their big thing. The smaller companies, have exit strategies. They plan to sell to a bigger company or go public or whatever it might be, and they, their data is what they have. They consider it hugely valuable, and certainly in the genomic space, it is now and will be later. But in terms of whether they're willing to share it, not right now. They're, it's a lot of what their value is there. So again, just something to think about. These things I think will change as policies develop and we make a plan on what we want to do with that data. Second piece of or thought I had relative to today was just the patient access comment, how we may want things to be patient-centric and how to develop this. There was an amendment to both CLIA and HIPAA that went into, or was enacted earlier this year, and it will be effective October 6th, which actually is giving patients direct access to their lab results, which will include these genetic and genomic tests. And there was a lot of discussion around it. It took a long time for the final rule to come out, and at the end of the day, it was a patient empowerment initiative, which is all good. What will be interesting to see is as people begin to get this data, what they'll do with it. On the one hand, without being paternalistic, it's complicated. Like these things are digitalized pathology slides. They are algorithmic p-value things in terms of the results. Most people probably won't know what to do with it. But at the same time, patients now get data and they upload it to mobile apps and they put it all over the place. So it will be easier for this data to be out there. So then it's a question of what privacy and security rules are going to underlie all of that. Certainly on the mobile app side, there's not very clear guidance on what you need to do. So those were kind of the two big issues I wanted to throw out there. I think when we think about genetic and genomic data, we have HIPAA, we have this new CLIA HIPAA final rule. We, of course, have the GINA, the Genetic Information Non-Discrimination Act, which provides some protection of that data. But you also have to worry about fraud and abuse and reimbursement, and FDA is regulating these labs now as well. So there's this whole range of issues that you're looking at legally when you go to try to figure out what companies can and can't do. So I think I've used my time up there, and we'll send it to someone who brought slides. I'll look bad.
I did. I thought I'm going to ask your indulgence to drag you into the crass, impersonal world of PowerPoint for a few slides. So if you can pull it up, you let me. So, and I'm a sort of practicing computer scientist, and so I feel compelled to speak with my crutch of PowerPoint. But Barbara, as you started saying algorithmic and p-values and all that, my eyes lit up. And
so much data.
Well, I'm at the Oak Ridge National Lab. We are a Department of Energy laboratory. We're in Oak Ridge, Tennessee, in East Tennessee. Have the fastest open science supercomputer in the world, and we are a Department of Energy facility that does a lot of computing, multidisciplinary, multi-science. And so you'd ask, what are we doing here? What am I doing here in this healthcare forum? As it turns out, the labs, as part of DOE and biological and environmental research, have done a lot of omics work over the years, especially after the Manhattan Project. But in the last, about 4 years ago, CMS reached out to the Department of Energy, HHS did, and set up an interagency agreement, and we brought our big data chops, as it were, to their problem of freeing the data. As you know, that's a huge value, and CMS itself is making tremendous progress in that area and releasing data, really doing it, making strides there. And we worked with them closely to prototype infrastructures that help show that it's possible. So I plan to just give you at least one vignette of what we did there to give you a feel for it. Let's go to the next slide. But just to sort of frame this whole big data in this space, I'd like to bring your attention to these two things that are happening in parallel. On the top is a sort of health-oriented, biology-oriented view of the proliferation of data. You have, sequencers creating gigabytes per hour of data. There's the omics stack, if you will, the omics, proteomics, transcriptomics. There's neuroscience now with these brain projects trying to make sense of our connections in the brain, all sort of surgically trying to go to the patient-centered view. So a lot of data there. At the same time, and so you can think of it as a sort of the continuum from the genotype to the phenotype, sort of the clinical view of the person through EHRs. The healthcare part of the world of care delivery and improving population health, as we move from the individual to systems and aggregations to the triple aim, is about making delivery work better. And the top space has been primarily the space of pharma and NIH, basic research folks, the national labs. The bottom space has involved healthcare, CMS, ARC in many ways. The VA, DHA is really concerned about that space, the finance and the workflow of healthcare. And a lot of the IT, the industry sector seems to play in that space. But I think what you want to be aware of is this general convergence of the patient-centered view and to the aggregate views, community-driven approaches that will sort of come together. And so if you think even of meaningful use and where it's going downstream is a sort of combining of EHRs, the phenotype view and the financial view, the claim stream. These two are right now not integrated, as I'm sure many of you know, but that's where they will come together and be linked together, and the analytics will need to be brought to bear on these two spaces. So that's what you want to project for and plan for. Next slide. So, one of what we did with CMS is we sort of worked with their proliferation of data infrastructures. And this is sort of one view of the connectivity of the data systems within CMS. And this is a reality of how computing has grown up over the past 30, 40 years. There isn't a magic bullet yet. So, you can't sort of stand back and be a critic. This is the story of many enterprises. The national labs, Google will have a proliferation of data systems behind. They'll have one system to run their finances, one system to run their customer relationship management. That's the reality of where computing is. As you click through, you'll see that if you sort of zoom in here, this is a view of one of a subset of their systems. Next click. Each system has a set of tables. Another click. With a lot of records and columns associated with each record, billions of rows. So if you look at A, B, Part A, Part B transactions, for Medicare, it's of the order of a billion, 1.2 billion claims a year. It's not big in big data terms, to be very honest, but it's valuable because each data element here in a claim is has much more information content than the click streams of an eBay or a Google click. So in those ways, although this is not intrinsically big data, it is big in the sense of being valuable and holds a lot of import. Now the challenge here that we all face in this, and as industry and federal folks, is to make sense of this data. And the reality is, in the past 10 years or so, computing has sort of found its sea legs more so, and the infrastructures are becoming available to assimilate and not be hamstrung by these data sets and to do much more in freeing the data. And that's what we did. And the next slide is sort of one example of how you want to corral this problem. And it's a prototype we built. We actually made it work. across many different infrastructures. You build it on the innovations of virtualization down at the bottom of the stack, sort of horizontal scale up. The cloud computing is all a commodity right now. As an industry provider, you want to have that in your quiver. As a federal buyer, you want to be asked for that and expect it to be made available. Above that, so there's a sort of data layer below. Above that, there is an analytics layer. And again, here the computer scientists have made significant strides in the past 15, 20 years to make sense of the data across disparate platforms. And this is what's interesting. It's not just one data set, but bringing together data across different silos and platforms, which is what everyone sort of grapples with as an organic sort of human problem. And above that, you can build these sort of delivery dissemination mechanisms for visual analytics, interactive ways. And again, there, as you have, I'm sure, noticed, not just in the mobile world, but even on our traditional IT platforms, the visual analytics interface has become much more flexible and intuitive. So that's something that, as an industry provider, you want to make sure that you do that and have that very much in your plans, because if you don't, a little agile startup will sort of chomp your lunch. And as a federal buyer, you want to ask for that as well, because if the big gorillas are not able to provide that for you, you can get it from a small entity. So what was interesting was we could do this across the different data sets. It's not intrinsically, technologically, some of the problems are not hard, they're solved. It's the procedure, the acquisition issues that sort of get in the way of making this seamless. So, the left has some visualizations of, customized community healthcare views, graph-based approaches to connect elements across these different databases, which I think, personally think holds a lot of promise. Next slide. So just a couple of sort of takeaway thoughts and maybe some recommendations for how ACT-IAC can help facilitate. To get to this learning federal health system, ecosystem, we can think of big volume, velocity, variety, and all those visigoths and all those V's that we have there. And you can think of scaling with technology, size, use utility computing, use massively parallel databases, use in-memory databases, column databases. Technology is maturing, so you want to raise your antenna to be tracking that and incorporating that, without a doubt. You don't want to sort of rest on your technologies of the 90s. And that's a sort of technology-focused solution driver. I think probably more importantly is a desire for not being stuck in the legacy trap and being vendor locked in. And I think this is where the trust between industry and the federal government, in my view, needs to get better. Because as I think feds, resource-strapped in staff resources that they are, they find, I think the federal government finds itself held hostage by vendor solutions that are not transparent enough, don't adapt enough to the new requirements. Because remember here, new requirements roll down from the people through Congress. And compute systems are not fluid plasmas, right? They have hardware and software, and so it's going to be a vital requirement that technologists, vendors, the industry build systems to be transparent in a way that they inspire trust that they can adapt as new requirements come. That's something that I don't see the industry designing to as much. And there are ways of thinking about creating representations of the data that are linkable, that are not sort of siloed. And so the plug and play and interoperability, just as one last point on that, becomes very relevant here, because if you want something to be flexible and swappable out in time to build trust, you want to think of standards and interoperability, but I have a sort of just a take on standards. We think of standards as a sort of an oracular sort of pronouncement on how we'll all come together and work. That's a fundamentally flawed notion. And I think I sort of caution folks who say, we want a standard. We find time and again that a group of smart people, well-intentioned people, will come together and call something a standard. And the rest of the world works around it. You know, stick stuff in the last tag of the XML document that says miscellaneous, and all the important stuff is out there. And that's a sort of human way in which we handle standards. So I would say tread with caution, and in fact, standardize something after you get de facto adoption. And so ACT-IAC can potentially work in creating that space which enables de facto implementation of systems, and then it gets standard post facto. So that then you can actually flatten the playing field.
Okay, so we're obviously a little bit beyond our time. I wanted to offer you all the opportunity to make some comments about some of the things that you've heard, or to raise an issue that maybe you didn't hear that you know, our panelists could address. Anybody have any issues? I'm going to pick somebody. Thank you, Dale.
Sure. So the old idea of transformation would cause you to think that we have a baseline transformation.
Yeah.
So what is the issue around defining our baseline? I get the whole idea. You brought up the standards. Standards can sometimes be great. You look at things in a certain way as opposed to a product. And I'm just wondering if each of you have thought about what does it mean to define a baseline which you're going to actually transform? And then what is it that defines the success of that transformation? Is it iterative? Is it more of that sprint kind of ideology and agile terminology? What is it you all aspire to or think about when you think about transformation?
Well, that's a good question. What's the goal?
Yeah, I think that's more important than defining the baseline, because the baseline is where you are right now.
And I would say that each of us look at that. And part of, I asked the question earlier around, well, is the definition of health IT something that the university grasps? The answer is no. Nobody defines health IT in the same way, and for a lot of reasons. The mission space is different, the economics are different, the demands are all different. So baseline by definition is something that's hard to grasp, right? Depending on where you're sitting. So I'm just wondering how you deal with that. Have you thought about it?
I mean, one thing that just comes to mind for me as a clinician is just how medicine has traditionally been practiced in so many different ways that it's never really been necessarily a standardized art in general. You know, I mean, it's the, you know, the doctor and the patient, and everybody does everything a little bit differently, and so that's part of the problem I think that we have as we're trying to standardize something that's complex and has not really been done in a standard way on paper. I mean, there has been some efforts to do it that way, but not consistently.
I can, on the privacy side, just to state what is probably obvious, but in terms of interoperability, I would think the baseline is kind of the old paper medical record where your stuff is pretty private when only your personal physician is holding it in their office. And I know, like, when my kids were little, we were active duty military. Every time we moved, you'd go and you'd get a huge copy of all this paper and carry it with you. So, you know, as we move away from that and toward interoperability, and not to say that that's a bad thing, but you know, you're losing some of that privacy because it's going to just be more available. So that's where our favorite thing kicks in, security, trying to make the data secure. And that, I mean, I'm not an IT professional like most of you probably are. You know, that's just a moving target. It seems like there's new stuff every day. When high tech first came out and we had all these business associates that had to start implementing the security rule, you know, from a lawyer, your big thing is, you know, avoiding breaches that require notification and all the hassles that come with that. Easy to do if you just encrypt your data. But back in 2010, right after the law, the IT people would look at HHS's encryption guidance, which is like this, and they didn't know what to do. They couldn't do it. Since then, I think things have just improved greatly. There's so many, they're finding ways to try to encrypt texting, and email certainly is encryptable. Though we still have kind of a divide, sort of on that health equity side. With some of our clients that are trying to do some of this health promotion with low-income populations, we run into problems where they want to do emails, do text to low-income people who they don't have smartphones. They're still working off of a flip phone. They don't have something that will decrypt the email when they get it. So you still have challenges there. But I think it's just a moving target is probably the best way to describe it.
So if I were to be a little reductive, to be reductive, I would say a baseline is if you have multiple copies of your data, and that's not a no-no. You should go to a place where you don't have that. If you don't have a governance strategy for your data, you want to go to a place that has that. So you can define these, and I guess it's a worthwhile objective to do that.
Shay?
Yeah, it's a really great question, and it's one that we've faced heavily in the VA and the DoD interspace. So the Congress has told us, for NDAA, if you're going to get your money, you need to exchange all data and make it semantically interoperable based on standards. And the great thing about all is that it's a singularity, but it means something different to everybody in the room, right? We all have our own singularity associated with that. So what does that mean? I mean, and if you're looking at from a data interoperability standpoint, well, that means medications. We all going to nod our heads, right? Does it mean all the medications you've ever had? Maybe, maybe not. And you start down this pathway and Margaret and I have spent way too much time trying to define the use cases of healthcare. When you get into the use cases of healthcare, it is an endless cavern, right? Because you talk about everything and you said, well, what did we talk about onychomycosis and fungal infections of the toes? No, we don't have a use case for that. Do we have the metadata associated with that? So getting into this baselining of for data interoperability in healthcare, of simply what is needed and what is necessary to practice healthcare is not really known. We have these core data sets and people pitching into that, but that needs to get defined. And then the success criteria is the old thing, if you don't know where you're going, any old path will take you there, right? But the success criteria is we have these belief systems that when we have data interoperability, things are going to be more efficient and we're going to deliver greater healthcare. We all nod our heads, right? Well, how do you measure that? So how do you measure, and this is one of the ones that I've really struggled with, how do you measure cost avoidance? How do you measure zeros? How do you measure now the fact that you have a hospital and you can see the MRI results and the actual MRI that I ordered in my hospital? How do we measure the fact that you didn't order that MRI again, right? How do you measure zeros? You don't measure zeros, that cost avoidance piece. And then is it then just a satisfaction piece? Is it just that you are walking into your hospital and they know and I feel better, which you do? How do you capture that? So we've really spent a lot of time on that definition of baseline and a lot of time of trying to figure out what success is, but it's really soupy, to be frank. To knowing,
and it's always going to change.
It's always going to change, and every time somebody comes into the environment, it's slightly different. And then when we get into the economic models of it, it is very different because, frankly, if you own a hospital, you may not want your providers to see the MRI that I ordered in my hospital because then you can't charge for that MRI, right? So you start to lay that economic model on top of there and it becomes, from a pragmatic perspective, even much more challenging. So yes, lots of, and we can talk at some point, lots of discussion about, if you're going to talk about data interoperability in healthcare, of what success may mean or may not mean and the baselining of that, but far, far, far from any sort of agreement in terms of what the targets are.
Yes, Mark.
So in terms of where I come from with acquisition and the Buyers Club, as everything shifts from paper-based to electronically, and all these different health IT dashboards, EHR, et cetera, right now we're developing our overall Buyers Club strategy. And with that, we're setting baselines. We're trying to figure out our baseline so we can assess metrics, so we can establish where success is, how we reach it. It's a very gradual, iterative process. It involves stakeholders providing input. you know, we found, and the reason why we have started this project is because a group called the Standish Group puts out this report every year, and they acknowledge that an extremely high percentage of IT projects in excess of $10 million fail for a lot of different reasons. And you know, we start with a problem, and we try to reduce that failure rate or increase the success rate. And so this is going to take a while. We're putting those baselines around where the current problems exist, and we're reaching out to all the different stakeholders to find out what they need to help identify that baseline, to reach the targets, to establish those metrics. And it takes a lot of different people to contribute, and it takes crossing the different silos that exist. And it really is going to take a tremendous amount of time to move that needle, because as you know, in a government system, nothing moves really very fast. We do and we don't. I mean, there's some that are really intangible, and although we're addressing some of those, we're trying to focus more on the tangible metrics. There's some IT projects that fail because they're over budget. There's some that fail because they don't include all the stakeholders. So our methodology really is going to boil down to using design thinking and doing a lot of end user interviews before we assess and identify those baselines. And there's going to be a lot of trial and error until we get to what we need to. It's just such a huge environment and such a large endeavor to tackle, but we have to start somewhere. And I know we're closing, I hate to take up time, but I'll put an extra plug in just because I think it'll help people. There's three things. One, if you're just any person, whether you were in the private sector or government, and you could email me at mark.nagar@hhs.gov. It's first name dot last name at hhs.gov, and I can share the information with you. The White House, in conjunction with us, we've established a public Google Groups page where we're putting all this information to share with everyone, whether it be use cases, so forth and so on. Secondly, if you are a federal employee, or a contractor and have a .gov or a .mil email address, we've established a federal-wide Buyers Club listserv. Listservs are old, but we're starting out somewhere. Hopefully moving to something more interactive in the future. Right now we've got maybe 105 members, and we're developing the strategy around that as well. That's maybe a month old. Same sort of thing. Lessons learned, pitfalls, moving the needle forward. Third piece, within HHS as well, if you're an HHS employee, we have a quasi-Facebook type page called Yammer, that network. And that also has a separate HHS Buyers Club page, which is much more interactive than a listserv. So we're slowly establishing the foundation so we can move forward and collaborate. And I found in the past maybe 2-3 months that I've worked on this, there are pockets of people all across every sector, federal and private industry, that are working on different things, but we don't know we're out there. And so we're trying to pull people together and collaborate to improve, again, set baselines, figure out the ways forward, collaborate. And I'm sure this is the same for other folks on this panel too. We're all working on a lot of these things, but we need to work together and find better ways to collaborate.
So that's the final question that I'd like to ask is so you just heard a problem identified. It's kind of like that sharing and governance model. So, and you heard that from our plenary speakers. My question is, what do we do about that? How do we change that governance and sharing model? Who should be responsible for doing that? Is it the government? Is it some organization, that's maybe, a .org in some way. But how do we bring all of this visibility together, or how do we identify that pathway? Because what we've asked you all to consider is, what are those things, those priority things that need to be addressed? What are those services that need to be offered universally to improve and transform healthcare? But how do we manage all of that? And so, that's the question that I'll leave you with, and unless one of you all has the answer right away.
She does.
Okay.
How it's split is there are echelons of need, right? So clearly, what a personal medical doctor may need versus clinical doctors may need will be totally different. So we have to first understand the complexity of that and not try to solve all kinds of things. From that, I think if you look at it from an echelon perspective, you can start to layer in what level of connectivity and collaboration makes sense. That is exactly something that's deployed. I think we start with that ideology and not try to solve it all at one time and go much further. But I think some areas will accelerate faster than others around the collaboration.
And should.
Just because of the passion and the need about it, versus others are a little bit more actually get better, but we treat them as we talked about, as a personal doctor with a different need than somebody else. We get a lot further.
Okay, so
I think the starting point, unfortunately, and we can talk about this later. I think there's a fundamental flaw there, and I think that's what we do now. Is what as a provider do you need to have for healthcare, or as an administrator for healthcare? The question really is what about you as a person who's getting healthcare, and you are the vehicle? What do you need done from them, communication, data exchange, whatnot, to make sure that you as the widget come out of the machine the best, right? I think we approach it from that perspective too much. And as a provider, I drive that at times, but that is that really uncomfortable thing of moving towards patient-centered care that we need to do.
So what I just heard is it's all about outcomes. What are the outcomes that we're looking for, and then we'll plan for how we're going to achieve those outcomes. So if you have ideas, I'm going to challenge you all to participate in the working group. If you have ideas that you didn't get a chance to voice here today, please send them to me, jteeter@kpmg.com, and I'll make sure that they get funneled into the process of the ACT-IAC work group. Okay? Thank you.